Good afternoon and welcome to the American Osteopathic Association, our webinar providing an update on COVID-19 activities and responses. We are grateful for all of you making time to join us this afternoon. And now please welcome AOA's Chief Executive Officer, Dr. Kevin Clower.
Thank you, David, and thank you everyone for attending. We welcome everyone to today's COVID-19 and AOA Public Policy Update, co-developed by the American Osteopathic Association and the Centers for Disease Control and Prevention. Before we get into all of the details of what's happening with COVID-19, we certainly would like to update you on what's happening from a resource standpoint with the American Osteopathic Association. And then we will welcome our distinguished guests to give you updates from the CDC perspective. So some of the AOA resources that are available have been developed very quickly in response to the needs and the recommendations and, quite honestly, the requirements of the osteopathic profession and the healthcare community in general. We've done a great many things, not in isolation, but in collaboration with many to make sure that we're meeting the needs, and we're trying to make certain that in real time we are addressing the demands that are put on people through the practice of medicine, and particularly in the osteopathic community. So through the AOA resource page that you will see that really identifies the COVID-19 resources that we're working on, you can find this on our website. You'll see updates on meeting status. So for instance, the American Osteopathic Association is responsible for conducting a great many meetings. And twice a week, we are evaluating the status of those meetings and whether they will be rescheduled, canceled, or conducted as scheduled. And you can find those updates on a regular basis directly on the website. Information about upcoming webinars are listed there as well. And I appreciate the over 500 people that are participating in this webinar, and really want to thank our wonderful physician services staff, including Cindy Pancala, for the wonderful Telehealth Resources webinar that was conducted last night, which hosted over 870 people on that webinar. And we will continue to produce these resources. We're giving updates on board certification information, and information created by osteopathic physicians as well are located there. All of the advocacy and legislative initiatives that we're working on are listed there as well. And our newly released telehealth guide is listed there also. And if you don't check this more than a couple times a day, you will most likely not see some of the updates because it is being updated on a regular basis. So a few other things that we want to mention in detail with the telehealth guide. We are providing you with private payer information. So how can you really implement the relaxed guidelines to be able to get reimbursed for these services at this time? What are the federal policy updates for the use of telehealth? And we are providing that information in written form and through webinar, as I mentioned. And then also providing any additional documentation that's provided from CMS to guide you along the way of implementation of this in your practice. We have links to CMS resources as well, and the newly minted COVID-19 codes that you may be able to utilize for testing as well. All of that is available in the guide, and we certainly provide this to you through that resource page. So now let's get into our update. And I want to introduce our guests. So Dr. Aoa Resources is an infectious disease clinician with over 30 years experience in the clinical management of HIV. He is presently serving as a member of the Healthcare Systems Coordination Team within the Health Systems and Worker Safety Task Force for the 2019 Novel Coronavirus Response. Dr. Resources was a hospital consultant and infection control specialist until joining the U.S. Centers for Disease Control and Prevention, or CDC, in 2007. He has served as the adult treatment team lead for the HIV care and treatment branch in the Division of Global HIV and Tuberculosis prior to his current role on the COVID-19 Health Systems and Worker Safety Task Force. Joining Dr. Resources today is Susanna Visser. She is the Associate Director for Policy in the Division of Vector-Borne Diseases. I will turn things over to our experts to give us an update on what's happening in the world today. Thank you both for joining.
Go ahead, please get started. Yes, we can hear you, and we're working to make her telephone line live again.
Okay. Thank you, everyone, for being on this call. I want to start out by just expressing the appreciation that all of us at CDC have for all of the healthcare workers that are on the front line of this difficult and challenging time that we face. I was asked to give a situation update and maybe discuss some things that you as providers can do moving forward in our nationwide fight against this pandemic. So just to give you an update on the situation, as of 10 o'clock last night, and all of this is available on the CDC website, there were 54,453 reported cases of COVID cases. They've been detected in all 50 states, along with District of Columbia, Puerto Rico, Guam, and Virgin Islands. 986 of these cases have been associated with close contact with another case, and 584 have been associated with travel to international areas. The other cases are either still being investigated or have an unknown source of exposure, and therefore we are assuming they are 52,000 are either still being investigated to determine the source of the exposure, or they have an unknown source of exposure, and therefore we assume them to be a result of community spread. And as most of you already know, the number of cases being reported in the United States is rising quickly, and the number being reported among travelers returning is now not considered a major proportion. So we do now report 13 states, which you can look on the CDC website to look at the map to see which 13 states are now considered to have widespread community spread of COVID-19. And of course, that is updated on a daily basis so that you can update what's happening in your local area. And again, also I would recommend that you listen to what your local health authorities are also saying to determine what the level of community spread in your community is. So as I know that some of this, just to review, I do think most of us know that COVID-19 transmission is primarily person to person, either through prolonged close contact close contact or direct contact with infectious secretions in the absence of PPE. Infected persons are thought to be the most contagious when symptomatic, but asymptomatic or pre-symptomatic persons we now know may play a role in transmission, but we are still trying to determine what the extent of that role is in the overall transmission of disease across the globe. Fever and cough are the most common symptoms over the course of the disease, along with the more severe cases. And so we now classify illness across 4 different categories: a mild URI, moderate pneumonia, severe pneumonia, and critical illness. We have the most data from China, where about 1/5 of patients were found to have severe or critical disease. And while most cases do occur in the middle age groups, the older age is the strongest predictor of COVID-19 associated mortality, along with certain underlying conditions such as cardiovascular disease, diabetes, and lung disease. Certain lab abnormalities, such as leukocytosis, may be considered predictors of poor outcomes, and chest X-ray and/or chest CT typically includes bilateral involvement with multiple areas of consolidation and ground glass opacities. While our call today is not meant to be a comprehensive summary of the clinical management of COVID-19, I do want to mention a couple of issues. As far as there has been some discussion about cardiovascular medications, primarily because one research group hypothesized that ACE inhibitors and ARBs may increase the risk of infection and severity of COVID-19. That is because there is some studies suggesting that the SARS-CoV-2 virus, which is the cause of COVID-19, uses ACE2 to enter cells, and ACE2 is upregulated with either ACE inhibitors or ARBs. However, there is currently no epidemiologic evidence establishing a link between ACE1 and ARBs and the risk of contracting or the severity of COVID-19. Therefore, the American Heart Association, along with the American College of Cardiologists and the Heart Failure Society of America, made the following statement: the continued highest standard of care for cardiovascular disease patients diagnosed with COVID-19 is top priority, but there are no experimental or clinical data demonstrating beneficial or adverse outcomes among COVID-19 patients using ACE1 or ARB medications. I also want to discuss the fact that there is currently no evidence to support changing NSAIDs due to risk of COVID-19. A while back, the French health minister suggested avoiding NSAIDs in patients with COVID-19, but there's been no current scientific evidence establishing a link between NSAIDs and the worsening of COVID-19. But the Food and Drug Administration, along with other agencies around the world, are continuing to monitor the situation to see if there is any new information regarding this hypothesized association. And then finally, on treatment, I just want to mention, I'm not going to get into a lot of treatment options but numerous clinical trials are underway, but as of now, there is no proven treatment for COVID-19 infection, nor any proven pharmaceutical approaches to the prevention of COVID-19 disease. I do want to talk a little bit about COVID-19 outpatient clinical management, which is primarily for patients with mild or moderate illness, as I classified earlier, that typically would not require hospitalization. So if you're considering taking care of a patient with mild or moderate illness at home, you should take into account what their underlying risk of progression to severe illness, including age and comorbidities, whether they're stable enough to receive care at home, whether they have caregivers at home, also whether a separate bedroom is available to prevent transmission in the home, and other necessities, including food, perhaps PPE for the household members, and other means of adhering to home isolation. I do finally want to mention on this issue that we have healthcare providers and health department staff with questions about healthcare providers and health department staff with questions about COVID-19 can access our CDC COVID-19 clinical call center 24 hours a day by calling 770-488-7100. This call center is staffed by trained clinicians who can assist with specific questions about CDC guidance for healthcare professionals, healthcare facilities, health departments, and laboratories. In terms of protecting healthcare workers against COVID-19, CDC guidelines recommend that you use a respirator or a face mask when respirators are unavailable. We do not know whether there is a difference between the level of protection between face masks and respirators, but we are concerned about aerosolized generating procedures. And so therefore, if you do have a shortage of respirators, we recommend that you limit the respirator usage to aerosolized generating procedures such as endotracheal tube intubation, BiPAP and CPAP, manual ventilation, and nebulizer treatments. And we do have some guidelines on the CDC website regarding these procedures. So finally, I want to talk about what we believe can be done in the ambulatory settings. And I think in terms of the ambulatory settings that many of you work in, I think that we can, we have objectives of the guidelines that we want to give in terms of what can be done in ambulatory settings. And we're looking for 4 basic objectives. One would be to minimize disease transmission to patients, staff, and others. The second would be to identify persons with presumptive COVID-19 disease and implement a triage procedure to assign the appropriate levels of care. The third would be to minimize the impact on the community's emergency room and hospital bed capacity. And the fourth would be to maximize the efficiency of PPE utilization across the entire health system in the community while continuing to protect healthcare personnel such as those on the call. So some of the actions that have been advised include delaying elective procedures or even elective ambulatory visits such as visits, and exploring alternatives to face-to-face. And I certainly was glad to hear about all the discussions that you are having as an organization regarding telemedicine options, telehealth options, and reimbursement for those options, because I think those are going to be an important tool for many healthcare providers to use in order to reach the objectives that I mentioned earlier. I also think you should consider adopting phone scripts to identify who might have mild to moderate disease and could be taken care of at home, rather than sending patients straight to the hospital that you think have COVID-19 disease because of the stress on your hospital system. And there may be a subgroup of patients that you're not sure about that you want to see in your clinic, and to be able to see those people in your clinic with appropriate precautions at your clinic is also important. You may want to consider posting signs at your clinic to allow for active triage of patients by calling a number rather than coming through the doors. Some clinics have even chosen to lock their doors with those signs and then have patients call before they are allowed to enter. You can engage with the healthcare community to see what role your clinic can play to relieve the stress on the local hospitals, while at the same time minimizing the need for use of PPE by your specific clinic. So for example, you could, if you have the capability of taking care of acute care illness that is not likely to require hospitalization, or even minor trauma such as small lacerations that could be taken care of in your clinic, that could be a way of relieving the stress of those type of patients from your local emergency room, so that your emergency room could be better equipped to take care of people with severe to critical manifestations of COVID-19. You should optimize the supply of your PPE to allow for other facilities to have adequate stock. So never too much and never too, but also of course never too little. Monitor the safety and health of your staff, including as we're saying for all employers, to make sure that we have liberal policies regarding sick leave, so that we do not have people feeling it necessary to come to work when they may be sick and potentially be sick with COVID-19. And as I mentioned, and then we mentioned taking advantage of the new telehealth regulation. So that is mostly what I wanted to go over with you. We did receive a few questions. Sue, are you able to talk?
I think I'm able to talk. Can you hear me?
Yes.
Huzzah. Great. And Elliot, there were just a couple questions right at the beginning when you were reporting out the case counts. You completely cut out. So there was a question of if you could just repeat those case counts, just that first piece of your statement. Could you do that first?
Sure. So as of 10 p.m. last night, the CDC reported that there were 54,453 reported cases of COVID-19. These cases have been detected in all 50 states, including the District of Columbia, Puerto Rico, Guam, and the U.S. Virgin Islands. 986 of these cases have been investigated and found to occur through close contact with another case. And 584 cases that have been investigated were associated with travel to international areas with sustained transmission among their close contacts. But the rest of the other 550, over almost 53,000 cases, are either still being investigated or have an unknown source of exposure and therefore are assumed to be a result of community spread.
Great. So David, Kevin, Sean, would you like us to go through the couple of questions that were sent ahead of time?
Dr. Visser, that would be great. And I also just want to flag two questions that I saw coming in the chat box while Dr. Reisses was talking. One was just a very sort of straightforward question about whether or not there's some sort of telephone number or hotline that people can connect with if for clinical questions along the lines of the information that Dr. Reisses was reviewing. And the second question had to do with protective equipment, whether or not some sort of Tyvek style outfit that would be purchased at a Home Depot that painters would typically wear, Tyvek overalls, could be used for safety, or if the protective safety equipment needs to be of some sort of medical grade. And then beyond that, I would say yes, please. It'd be great if you could go through the questions that we had sent in advance.
Okay. So this is Dr. Visser. Do you want to just start with the previous questions, and then we'll tag those two on the end?
Wonderful. Thank you.
Okay. So the first one really is for Dr. Reisses. Please share any update on progress being made to expand testing capacity, along with information on how and where to direct patients with symptoms.
Okay, so thank you for that question. As you know, there continues to be some issues regarding testing capacity. Because we are not at the level of capacity that allows on-demand testing. For the on-demand testing, the decision has been made at the national level to prioritize people with symptoms in the moderate or even severe category, or people or healthcare workers or people in higher risk groups, such as people with comorbidity and advanced age above 65. However, we are also finding that there are extreme heterogeneity in local availability of testing and local policies regarding testing algorithms. So I think it's important for the people on this call to be aware of what those algorithms being recommended by the local authorities are, and then and follow those guidance. We are trying to further refine. For now, we are using influenza-like illness as a proxy for possible or suspected COVID-19 infection. We are still exploring how to further refine that definition so that we can actually create a case definition that is without testing. But for now, most of the case definitions that you see are associated with actual testing being performed. And then I would just go back to what I said earlier about because the lower risk mild to moderate illness is not associated with a high mortality or even poor outcomes, we do recommend that you advise patients who appear to have to be in that category, if you deem it safe, to have them ride out the duration of their illness at home, with the idea, of course, of checking in with them and setting criteria for when they should go to the hospital.
Okay, great, thanks. So we had a second question sent to us. What is being done to increase the availability of personal protective equipment and other medical supplies to hospitals facing shortages? And several of you may know that a couple of years ago, our strategic national stockpile, which it has been set up to ensure that we have access to personal protective equipment and other medical supplies that might be needed during a pandemic, during a bioterrorism attacks. It was transferred from CDC over to another part of the Department of Health and Human Services, ASPR, which is the Assistant Secretary for Preparedness and Response. And the Strategic National Stockpile is now managed by ASPR. They are working to try to disseminate as much PPE as they have. They definitely are experiencing shortages themselves. They're working every supply chain angle they can to replenish that stock and distribute it. The way it works is to the state stockpiles, and the state stockpiles further distribute it out to hospitals, state and local public health organizations, and others. So while they are doing that and working the supply chain the way that they normally would, attempting to procure as much PPE as possible for this particular pandemic, FEMA has also stepped in to help with distribution. They're really fabulous about moving people and product to places. And so they were called in just last week by the White House Task Force to help with that process. That will help get things to where they need to be faster. They also, FEMA has a coordinated donation mailbox and a sales website for those who have product and are trying to contribute it, but kind of don't know how to do it. And we want to make that as coordinated as possible. So FEMA does have that website and can move everything into one stream and support ASPR in their dissemination of the Strategic National Stockpile product. I hope that helps with that question. Our next question was for physicians not working in hospitals who are seeing patients either face-to-face or virtually. Is guidance being developed for where to send patients in urgent need of medical services that are unrelated to COVID? Dr. Reyes, do you want to take that one?
Okay, thank you. Yes, I certainly can understand how this is either is or is going to become a major issue in the communities where you are working. I think that, first of all, we are, as I mentioned, we are continuing to collect extensive epidemiologic information about the cases, about many of the cases that have been reported, and including longitudinal data to determine their outcomes, so that we can make all of the all the healthcare providers in this country comfortable with, guided algorithms on who should be sent where in urgent for COVID. And then, as far as other medical services are concerned, unfortunately, I think these people, are going to have some difficulty obtaining those medical services, especially if emergency rooms are overloaded. So, as I mentioned earlier, if you're not working in an emergency room and you have a clinic where you're comfortable with patients that perhaps historically have been seen in emergency rooms, using the proper screening procedure to make sure you are not being asked to see them for a potentially severe respiratory illness that could be COVID disease, then I think volunteering or promoting that on the part of your practices, I think would be, we are hoping that can be a good way to help get the proper care for the people that are not suffering from respiratory illnesses. Whether that's in face-to-face, whether that's through some sort of telemedicine initial screening to determine whether a face-to-face visit is necessary, I think would depend on the individual context. Thanks.
Okay, great. So we had a question about how are resources being shared with state and local health departments, and how should physicians be engaging with and leveraging their state and local health departments. So you may know that CDC's bread and butter is really funding those state and local health departments. And on March 6th of 2020, the COVID Preparedness and Response Supplemental Appropriations Act was passed, over $8 billion to help support the COVID response. And $950 million of that was allocated for state, local, territorial, and tribal jurisdictions. And we quickly moved to push out as much of those resources, as well as some of our reserve dollars, out to state, local, territorial, and tribal organizations. To date, $604 million has gone out, released to those public health organizations and departments, and more is coming. That money went across 65 different jurisdictions. They're all of our states, plus big cities and tribal organizations. And we are really working to try to support epidemiology, laboratory activities, as well as general response activities. I would say that, in terms of engagement with state and locals by physicians themselves, Dr. Reyes, do you want to say anything about that?
About physicians?
About how physicians can engage with their state and locals, their health departments.
Yeah, so as I said earlier, I think it's important to, so number one, I think it's important to understand what the situation is close to home for you, and also to follow the guidance of the state authorities regarding testing procedures, regarding care in the home, regarding what precautions should be taken, what the supply of PPE is in the community. Those are all things that I think you should be engaging with your local authorities on. And also maybe getting back to the question that came up during my talk about I had mentioned the clinical call center, and that number again is 770-488-7100. Perhaps AOA can post it on their website. But I think that's an important resource. It's an important resource really in a bilateral way. And what I mean by that is that not only do we want to have that resource available to you in order to be able to help you with the care of an individual case, or perhaps even a household situation that we also hear about often, but also by seeing what comes into this call center. We are tracking what comes into this call center, and that actually gives us the necessary information order to provide guidance on the CDC website for the entire population, even you know, because this is a public website. So I think that, that's the importance of, and so I think the same thing is true in engaging with your state. If you're not engaging with your state, telling them what you're seeing, then it's hard for the state to know what the proper policies they should be implementing at the time. And as Dr. Visser can attest to, we are updating the CDC website literally daily, if not hourly, with new guidance based on the feedback that we're getting from people's experiences in the field.
I can definitely attest. Great. So the last question that we had mentioned before Dr. Reisses was about PPE and Tyvek overalls that you can purchase at Home Depot. Is that appropriate to use maybe more in a crisis management sort of situation, obviously, not as a first choice, but as maybe a second or third choice option?
Thank you for that question. I am definitely, we have a worker safety section of our health systems task force. We unfortunately do not have anyone on the phone right now from that task force. So number one, we can refer that question to them to see if they have an answer that they can send back to AOA to share with the members. And secondly, I would also just pay attention to the space that I just mentioned, because we are constantly putting up new guidance regarding worker safety, and we are starting to put out numerous documents related to alternatives to classic PPE. And so without mentioning any specific product, because that's beyond my level of expertise, it is true that these ideas are being looked at carefully by the experts across the spectrum of the worker safety realm.
Okay, and I don't want to take over. I know we were supposed to be done in the first 30 minutes of your call, so I don't want to take over all of the time. I am noting all of the open questions, and many of them are infection prevention and control questions that Dr. Reisses and I can work to get answers to, and perhaps maybe we can send them back to the AOA leadership for distribution after this webinar, if that works for you.
Dr. Visser, that would be wonderful, because I also want to be, you know, respectful of both of your time, because we certainly appreciate all of the work that the two of you are doing. I know that you have important work to get back to, and if you'd be amenable to answering those questions, because we've been trying to keep track of them, you know, we can certainly disseminate that information on our website as well. So that would be wonderful. Thank you.
Great, will do. I'll take care of that and send responses back to you in the next few days.
Thank you so very much. And Dr. Reisses, thank you for all of your time and all of the very important and useful information that you've shared with us this afternoon as well.
Well, again, thank you to all your members for all they do for our population in this difficult time.
Thank you. And again, please call on the AOA if we can be a resource and a partner in supporting your efforts as well. So thank you again.
Thank you.
So with that, you know, the AOA staff wants to spend a few minutes. This slide is titled a legislative update, but in fact, it's probably more appropriate to really call it just a policy update. Dr. Reisses at the start of his talk was providing an overview of some of the incidence data, the numbers of confirmed cases in the United States, and those numbers really, one of the most remarkable things that I know certainly all of you are aware of and appreciative of is just how quickly these numbers are changing. You know, at the start of this month, I think on March 3rd, there were maybe 100 confirmed cases in the United States. 10 days later, we were up to about 1,000, and now here we are on March 26th, and as of a little after 12 noon Eastern today, we were fast approaching the 70,000 mark in the United States. And I think since this screenshot was taken, we've crossed the 75,000 confirmed cases in the U.S. mark, which is quite astonishing and illustrative of the magnitude of the problem. The red on the map of the United States indicates where those cases are. So obviously the more red, the more concentrated the cases are. And so really, as I said, this isn't just a legislative update, it's a policy update. On March 13th, the president issued an executive order declaring COVID-19 to be a national emergency. One thing that the administration has really been doing well over the last few weeks has been its work through the Centers for Medicare and Medicaid Services, updating guidance and facilitating coverage for telehealth services, expanding the use of telehealth, allowing for physicians participating in Medicare to provide in-person and telehealth care to patients in other states to really expand capacity, providing waivers through Medicaid. And we also see states broadening access to coverage as well. So as of just a couple of days ago, 11 states in the District of Columbia have opened up special enrollment periods in their state exchange programs. It's possible we could see the federal exchange follow suit as well. I mentioned briefly the Medicaid waivers from states. So far, at least 13 states have requested Medicaid waivers, which suspend prior authorization requirements, make it easier for physicians and other healthcare professionals to participate in their state Medicaid programs. And to facilitate ongoing changes in state Medicaid plans to make it easy for people to get covered and have their care compensated when they're Medicaid beneficiaries, and that includes obviously telehealth requirements. So getting back to what's happening on the federal legislative front, as you heard Dr. Visser describe, we are in the midst of Congress approving a third stimulus package, a third legislative package to address the problem. The first package was the $8.3 billion package earlier this month that was largely focused on research for vaccine development and for testing. Then we had just last week, we had the second big package, which is $100 billion. It focused on expanding federal funding for paid sick leave and family medical leave, expanding unemployment insurance, and then also covering supplemental nutritional assistance programs as well. And then the third package, which the Senate passed last night, the House of Representatives is expected to pass tomorrow, and the president will sign into law, really covers the waterfront. It's $2 trillion. It's hard to really put $2 trillion into perspective, but we all remember the financial crisis of a decade ago, and there was the big bailout of the financial industry, there was the big bailout of the auto industry, and there were other stimulus programs, and this is bigger than all of that combined. And this covers, as you see here, economic support for different sectors, as well as financial support for individuals, but it also puts a lot of money into healthcare, which is primarily where our focus has been. And so here you just see this shows what's been in each of the three packages. And this most recent one that's currently making its way through Congress invests in healthcare, invests in individuals, and helps hopefully support the economy, as well as small businesses. Just a quick word on that bottom right box. As far as the small business support, we recognize that physician practices are structured as small businesses. So we are in the process of reviewing the details of the small business provisions to see if and how they would be applicable to any physician practice that might be in need of financial support as well. So there's a lot in there. As I mentioned, $2 trillion covers a lot of ground. So just to cover the highlights here, and I recognize this slide is very busy. On the left-hand side, you see the funding highlights. This is not obviously covering $2 trillion worth of funding highlights, but just a few items that we think would be of interest. $1 billion for the Department of Defense to help support utilization of the Defense Production Act to secure the procurement and development of personal protective equipment, safety equipment, other medical supplies such as ventilators, $4.3 billion for the CDC, which you heard Dr. Visser run through, so I don't want to spend much time on that. But the big chunks of money there, $1.5 billion for state, local, and tribal health organizations to purchase equipment and support testing, surveillance, and other important needs, $1.5 billion for additional CDC activities, $100 billion for grants to hospitals, other nonprofit entities, healthcare providers, to really focus on offsetting unreimbursed healthcare and healthcare-related expenses or lost revenue, $16 billion to support the National Strategic Stockpile for medical supplies, and $5.5 billion for vaccine development and acquisition. I will mention very briefly, the AOA will be putting together a more detailed summary of what's in this package, which we will be sharing with our members. So more details to come. There are non-funding highlights worth mentioning as well. Briefly, a few of those include allowing high deductible health plans and health savings accounts to cover telehealth services prior to a patient reaching their deductible, allowing patients to use funds in either health savings accounts or flexible spending accounts to pay for over-the-counter medical products. This is something the AOA has been advocating for a long time. We're glad to at least see it being implemented relating to COVID-19. The package also eliminates some of the limitations that were included on prior expanded Medicare telehealth authority, so really further expanding coverage and use of telehealth in Medicare. One here that is very important for federally qualified health centers and rural health centers, allowing those clinical settings to serve as distant sites for telehealth consultations, to provide telehealth services, and to be paid for these services by Medicare. We've also been working for a long time to expand Good Samaritan protections for physicians. So that's been included as well in this package, but it is important to note that this is limited to volunteer healthcare professionals. So if a physician is being compensated, being paid for the services they are furnishing, this would not be applicable. But for somebody who is stepping up, because we do know in a lot of areas where the healthcare system is being overrun, there are calls for physicians to volunteer. If you are volunteering, if you are not being compensated, this would apply in that instance. And then, as I noted before, financial support for small businesses and not-for-profit organizations as well is included, and that's actually very significant and something that we're trying to unpack the details of very quickly to share. So despite this being a very large $2 trillion package, there still are some very important issues that were not addressed in this legislation, which means much more work remains, and we are certainly going to need all of you, members of the osteopathic community, to partner with us in addressing some of these important needs. One of those is this critically important issue of paid sick leave for the healthcare workforce. It's very important to note that in the second COVID-19 legislative package, and I did mention it before, Congress expanded federal funding for sick leave. However, because the hospitals were concerned about having an adequate workforce and they were concerned about staffing, there was a carve-out included that allowed for any healthcare employer to not participate and not expand their sick leave program. And so we are working to get this addressed in the next legislative package, and we don't know what the timing will be. It could be a month from now, but it's widely assumed that Congress will need to take up another legislative package sometime in April, and this will be a top priority for us in that vehicle. There may be a need to look to mandate or support further utilization of the Defense Production Act or oversight of how personal protective equipment is being priced. So that might be something else that we will have to be looking at. And then also, again, the funding provided for state and local health departments or small business coverage for physician practices might be insufficient, and we might need to take another look at those as well. There are other outstanding policy issues that we also are working to get addressed. So surprise medical billing might be something that gets put on the table as part of another package, addressing prior authorization beyond COVID-19, beyond what's been done in some of these Medicaid waivers is something that we're working on. We have also a number of important public health programs, such as Teaching Health Center Graduate Medical Education or the National Health Center Service Corps, as well as funding for community health centers that has been temporarily extended from what was an impending deadline through the end of November. So that's something that we need to work on getting reauthorized and potentially with an increase for several years as well. And then, of course, looking to see that chronic care management codes can also be fully utilized. So we have a lot of work ahead of us, and we hope that you'll be joining us in that effort. And with that, I'm going to turn things over to Sean Neal so he can talk about our advocacy work and how members of the osteopathic community are and have been engaged and certainly can continue to work with us, because your voices really are so critical. So with that, Sean, I'm going to turn to you.
Thank you, David. First, let me start by saying that I'm really proud to work for an association that supports the hardworking osteopathic physicians and students that are on the front line battling this pandemic. I know that many DOs and osteopathic students have made sacrifices to keep our nation safe, and I really just can't thank you enough for that. And so we at the AOA are doing our best to support you through advocacy efforts, and I hope you are able to make a difference, and I hope we are able to make a difference by getting some of the items you so direly need in the stimulus package. So let's go ahead and take a look to see what we've done so far for our COVID-19 advocacy efforts to date and what still needs to be done. First, we want to keep our members informed and updated on all legislation that relates to COVID-19, both on the federal and state levels. Our team put together an interactive map that lists COVID-19 bills that are moving or have passed in state legislatures in real time, and that's what you see there on the slide. It's really easy to use. You just simply click on the state that you live in to see the bill, and on the map, you will see the status of the bill, last timeline, any public hearings, and of course, you'll have a link to the full bill. Most of these bills are stimulus packages, but we just want to keep you as informed as possible during this pandemic. Second, we sent letters to Congress and the administration illustrating many of the concerns that we have heard from you. And, as you know, the AOA is a truly physician-led association. And so to that end, we launched a Tell Your Story campaign. We know, again, that you're on the front lines treating this pandemic. So your stories really helped us craft letters and advocacy alerts to help bring a clear picture to lawmakers on what's happening on the ground and the gaps in coverage and resources that need to be still filled. The collection of stories and information is ongoing, so that'll be important for our future advocacy efforts, and we'll get into that a little bit later. We also know that lawmakers need to hear directly from you, the constituent, to help guide legislation. One of our first advocacy alerts on COVID-19, we asked our membership to send an email to their lawmakers advocating for increasing the supply of PPE, shielding physician and other healthcare professionals from additional liability for volunteering their services in response to a disaster, and then finally reauthorizing the Teaching Health Center Graduate Medical Education, or THCGME program. The deadline and cutoff date for the funding was May 22nd, so that was extended, and we're grateful for that. But from this alert, we generated more than 500 letters to Capitol Hill. And as you know, the pandemic got significantly worse, and legislation addressing it was constantly being updated, so we knew that we had to up our grassroots efforts. We launched another campaign that allowed not only physicians to participate, but anyone who visited our action center. The language in the new grassroots alert was a little more dire and direct, and painted an even clearer picture that physicians need PPE now, and without it, patients and health professionals will suffer. So we also wanted to address that the physicians were being excluded from, as David mentioned earlier, expanded paid medical leave, and that all other workers across the nation were provided. We wanted to create a movement and get the osteopathic perspective heard in this campaign. And to do that, we knew that we had to get more individuals involved. So example, if your friend is a lawyer and wanted to help show his support for you, he could take action on this alert as well. It is designed to inspire anyone and everyone who participates, not just physicians. As for the mechanics, the new alert worked very similar to our first alert, which allowed individuals who logged in to send their members of Congress an email with a simple click of a button. And we generated quite the buzz for this alert. We sent more than 2,000 letters to Capitol Hill in really just a few days. Our online grassroots activity really didn't stop at letter sending. We also had a social media, we had a social media campaign as well. And it has a growing influence on members of Congress given its public nature. It allows the lawmakers to connect with their constituents faster than ever before. We know from recent advocacy studies, it takes far less grassroots activity and engagement directed to lawmakers to get their attention if it is done on social media. So given that it's public and open for everybody to see, I think it makes sense that it takes less advocacy efforts and engagement to kind of get their attention. So we wanted to put our physician's name to a face for the member of Congress and encourage our advocates to tweet their lawmakers expressing their concern on PPE shortages as well. We generated pre-populated tweets for our advocates to send not only to their members of Congress, but we also wanted to provide visibility to their governor as well. Again, with one click of a button, our advocates can tweet directly to their lawmakers' Twitter handle. We wanted to create a seamless and easy process for our advocates to engage, and we're hoping we accomplish that for you. We also encouraged our advocates to spread the word through their social networks as well. We wanted to create a social media toolkit that walks all our advocates through everything that they need to know to help influence lawmakers and encourage their peers to act. Our advocates and members are leaders. We know that they're leaders in the osteopathic profession and their community. So their peers really look to them for guidance and support. For those that you can see the slide, I think this is what leadership in a grassroots movement looks like. Through our social media toolkit, we encourage our advocates to link our PPE letter writing campaign to their social media platforms. Within the toolkit, we had example posts, but encourage the advocate to add their personal story or flair to it. As you can see here, one of our top advocates, Dr. Shahid Sel, has participated and encouraged her network to engage. And, for me personally, I think that this type of engagement and advocacy, I just personally love to see. Her post generated a conversation amongst her peers, and within that conversation, many individuals said that they took action and posted the response that they received from their lawmakers. In addition, individuals within her network saw the post and decided to share via Facebook. So if people see multiple of their peers passionate and participating in these campaigns, it's more likely that they'll engage as well. And we didn't just stop at Facebook either. We encouraged our advocates to post on all social media platforms. As you can see, our CEO, Dr. Kevin Clower, and ACU President, Dr. Thomas Dardarian, leading by example here, encouraging their network to engage on Twitter. Dr. James Griffin also encouraged his colleagues on LinkedIn to advocate as well. And so these are just a few examples, but there are many more that made the commitment to engage and encourage their peers to act. And I think the wider net we cast here, the better. To expand even further on our advocacy efforts, we encourage members of the Osteopathic Advocacy Network to attend town halls that many members of Congress are hosting virtually. Max Goldman from our public policy team is doing a really exceptional job running this initiative, and it allows you to participate in your lawmakers town hall where you could potentially weigh in on how Congress should respond and the problems that you and your colleagues are facing. I can share with you that just this morning, our own AOA president, Dr. Ronald Burns, was able to participate in a virtual town hall himself with his member of Congress expressing his concerns on his behalf and the AOA. We put together a town hall toolkit that walks you through the process and how town halls typically operate, the etiquette, a suggested question for you to ask, and how to follow up with AOA staff. If you need additional materials, we're happy to provide them, and any kind of additional training that you may need, just give us a call and we're happy to provide that. I should also mention that all this is available by signing up for the Osteopathic Advocacy Network. So if what I just ran through sounds interesting to you and you want to engage in a higher level of advocacy, I really encourage you to sign up. It's completely free and it's easy to join. Just click the link that you see on the slide there, or you can also visit www.osteopathic.org/grassroots and you can sign up there as well. So what did our advocacy and grassroots engagement give us? You know, I think David highlighted some of it, but I mean, you know, in my opinion, it got us quite a bit. You know, the new stimulus package includes liability protections across state lines in response to COVID-19, additional funding for PPE, and funding the THC GME program until November. This really couldn't have been accomplished without individuals speaking out and engaging in advocacy. But I will say that there's more to be done. You know, healthcare professionals are still not covered for expanded paid medical leave, and we have the opportunity to get that included in the next stimulus package. So while we're upset that DO Day on Capitol Hill was canceled in person, we know that there are many other ways to engage, and many of them I mentioned earlier through email, social media, by participating in town halls, and so on. But I will say that it's so critically important that we stay engaged, especially in light of this pandemic. Advocacy really never sleeps, and you just have to constantly be tilling the soil. And that's why we're having a virtual DO Day of action. So on Thursday, March 31st, we are asking for a swell of advocacy engagement by encouraging our membership to send their lawmakers an email, post on their social media pages, and potentially attend virtual town halls. And we'll have a little more as well. But in the next few days, we will provide you with a virtual DO Day toolkit, and we'll list how you can participate and how you can stay engaged. It'll just give you instructions of step-by-step of what you can do to engage virtually. But in the meantime, I really do strongly encourage you to sign up for the Osteopathic Advocacy Network. I think it's a great tool and opportunity for osteopathic physicians and students to engage in just kind of a deeper level. And I know we're kind of running behind on time here, so I want to just wrap things up and turn it back to David to discuss the next steps.
Thanks, Sean, and thank you all for your time this afternoon. I know we're a few minutes past the top of the hour, so let me just close with a few notes. A couple of questions were about Aoa Resources payment for telehealth that I noticed in the text box or the chat box. As Dr. Clower mentioned in his introductory remarks, the AOA is constantly updating its online resources. So if you go to osteopathic.org, what you will see right on that homepage is COVID-19 updates for osteopathic physicians, and then there's a button to click to learn more. So when you then go onto that COVID-19 webpage, there's really no shortage of information. And as you scroll down, one of the sections that you will see highlights a telehealth guide. And this document was created last week. It was revised this week on March 24th. So there is really useful information as well as a number of links to get additional CMS resources. So if you have a question about coverage or payment, there's also links in there to the CDC site as well, and the World Health Organization, as well as codes for Medicare and as well, and private payer codes as well. Highly recommend checking out that website, and this particular document is very useful resources. As Dr. Clower mentioned, all of these materials and that website will be updated each week throughout this pandemic. And as Sean said, we're very quickly digesting what was in this legislative package. It's the acronym, it's called the CARES Act, that the Senate voted on last night. The House is expected to pass tomorrow, and then we'll be putting out new action alerts to address any unresolved issues with sick leave coverage for the healthcare workforce being at the top of our list. Please consider the AOA a resource for your needs. If you have public policy questions, do not hesitate to reach out to Sean or myself or anyone else in the public policy department. And we have done our best to take note of all of the questions that have come in that have not been answered. We're going to be taking the responses we received from the CDC and compiling that into an FAQ of some sort or a response document that we can publish, and we'll certainly share that with everybody who registered for this webinar. So again, thank you for your time today. Thank you for your engagement, and we look forward to being able to work with you to continue to address this public health crisis. Thank you again.